Let's get into blood pressure, Justin. So I'm going to throw something at you here. This is, I'm sure this is true. We are fantastic at treating blood pressure. Most patients that have high blood pressure are at goal. How are we doing overall? Am I right?
So
great?
I think the four of us are probably thriving.
Yes.
I like to think that the four of us are
especially America's PCP, Dr. Paul Nelson.
National treasure.
Yes.
But so here's what I took away from the hypertension. A couple of big things about national trends. First, as you all know, in 2017, the new guidelines made stage 1 hypertension at systolic blood pressure greater than 130. Mm-hmm. So that in and of itself increased the prevalence of hypertension, which I think was an oops. I think that was, we didn't see that coming.
30 million, by the way, like not a small delta.
Not a small amount, a very large number.
They wanted us to treat more people or just recognize it and get more people into treatment early. I understand where it was coming from.
It's all about maximizing, optimizing outcomes, preventing mortality. A lot of the details from the SPRINT trial of really trying to work towards improved outcomes with more aggressive blood pressure.
Right.
So because we know all this information, I agree with you, Matt. We would think we're doing stellar, but it turns out that not only are we not doing well at getting our patients' blood pressure under control, but there is a decreasing proportion of patients who have their blood pressure controlled over the past decade, even without those guideline changes.
Yeah. Yeah, even if you look at the 140/90 goal, we were still not doing that great. So then when you lower when you lower the bar, it just made it even harder to get to the right.
Yeah. So, I think that as we talked about, this is all meant to really identify we need to be more aggressive, in part because it's a form of primary prevention, of preventing heart attacks and stroke. We need to be getting people on medications. And in part, one of the slides that she showed from the 2017 guidelines that you saw a lot of phones come out to take photos of was the algorithm and pathway that basically shows if you have someone in stage 1 hypertension with a systolic blood pressure greater than 130, so someone coming in 132/82, the recommendation is to do a calculation to look at their ASCVD risk score. And if they're over 10%, you need to be aggressive with their hypertension. And so the recommendation is to start BP lowering medication right then and there.
And Paul, you pointed out, I think this is a consensus recommendation, not a based in...
Right, because this risk calculator was designed to calculate ASCVD risk for lipid control in patients 40 to 70 and not for the specific group. And this is not something that was looked at specifically, I don't think so. It makes sense that a high-risk patient should have tighter control, but makes sense is not the same as a randomized control trial using this actual calculation.
And what we know, essentially what we know about blood pressure is that lower is better for the most part. It's hard to get people too low. So we'll just say lower is better, meaning closer to normal. And then that the longer you have high blood pressure, the worse it is. Even talking to dementia prevention and things like that. So I think that's why we're trying to identify people early and be more aggressive about treating.
It all makes sense. When you're thinking, sorry, not to run away, but if you talk about sort of toxic exposures, whether you're talking about to high blood pressure, to lipids, to hyperglycemia, all of it is the duration of exposure matters. It makes sense, but also again, makes sense is not how we should be building a lot of these recommendations definitively. Hopefully it's being studied, and I'm sure it is.
Yeah, and I think a lot, kind of does still fall on expert opinion, and she was a wonderful expert. I didn't mention Dr. Shauna Nesbitt from UT Southwestern, who's the director of their hypertension clinic there. And in line with what you're saying, she really brought up this life's essential 8 concept of eating better, being more active, quitting tobacco, sleeping better, managing weight, controlling cholesterol, managing blood sugar, managing blood pressure, all of these kind of holistic approaches. And one that I admit I was not aware of, it's a study from 2018 that kind of looks at the social factors of some of the racial disparities. Some of the social determinants of health are a major part of cardiovascular risk. But there's a study in the Regards study from 2018 that looked at what are the clinical and social factors that are associated with excess hypertension risk in Black communities. So in Black communities, we know that they have a higher risk of hypertension. There's a higher risk of heart disease, what's going on there. And one of the biggest mediators of hypertension difference in this study was linked to diet, which attributed to about 50% of the excess hypertension risk in Black men. I think reinforcing this idea that race is not genetic, that race-based medicine is not good medicine. We need to be approaching it from understanding the social differences. And this was one that really demonstrated that diet is associated with hypertension end-stage renal disease, sepsis, cancer mortality kind of decline, and attributed especially in some of these racial disparities.
All right. Well, we have check out. We have lots of blood pressure episodes. One with Dr. Von Pattanassen from UT Southwestern, and then two recent ones with Dr. Jordy Cohen from Penn. So lots of great stuff. My take home is be more aggressive early on, especially if people are very far off goal. And I'm using a lot more combination medications, even at low dose. I find I have just better control that way rather than starting one agent. And then I feel like I'm getting people under control faster when I'm using combination therapy earlier on.
Yeah, I found doing nothing doesn't seem to help as much as adding stuff.
Yeah, don't just stand there, give them blood pressure medicine.
Yes.